Welcome, everyone. And we're going to start this evening off with land acknowledgement right at 7:30.
My name is Carolyn Nowry. I'm a family physician in Calgary. Calgary is in traditional Treaty 7 territory. We have participants joining us from across the province, and we would like to recognize that our work takes place across the territories of Treaties 6, 7, and 8, and the homeland of the Métis Nation of Alberta, including the Métis settlements.
Je reconnais respectueusement que je suis située sur la terre du Traité 6, territoire traditionnel des Premières Nations et du peuple Métis.
At some point, for most of us, our families immigrated here and began new lives in this new land. Many Indigenous peoples were displaced from their traditional lands and ways of life. This began a chain of atrocities, the effects of which persist to this day. The deaths of Brian Sinclair, Joyce Asechewan, and recently Lillian Vanasse in Hanna, Alberta, are the result of ongoing systems of racism. Land acknowledgements should not become just another checkbox that we do at meetings. I'd like to invite all of you to take a moment and reflect on how we can take a role in interrupting racism in our practice.
I'm Dr. Janine Karpakis, a family physician here in Lethbridge, which is Treaty 7 country. I am an international medical graduate from South Africa. There are significant deep-rooted stereotyping of Indigenous people when it comes to substance use disorder medicine and other psychosocial issues. And it's interesting to note the similarities between my childhood exposure of racism in South Africa and the impact that colonialism has had here in Canada. It is my opinion that we as a medical society need to acknowledge the presence of systemic racism to start conversation towards bridging the divide in order to allow for healing.
So welcome, everyone. And I hope that land acknowledgement gives us something to think about in answering the Truth and Reconciliation calls to action. I'm Kathy Scrimshaw. I'm a family doctor down in Pincher Creek and the medical director for the Collaborative Mentorship Network. And it's my pleasure to welcome you to tonight's collaborative forum. We have a great speaker lined up, but we're first going to deal with some housekeeping. If we go next, the disclosures, as you know, I am Kathy Scrimshaw. I am a part-time paid employee of the Alberta College of Family Physicians, and I have no other financial disclosures to make. My team tonight is Dr. Leah Phillips, Carrie McNabb, Maya Mudrick, and Jared Leader. And they also are paid employees of the Alberta College of Family Physicians and do not have any other financial disclosures. So some housekeeping. To grab your attendance tonight, click on the survey link. It'll be in the chat log a couple of times and you can enter your name and email. We also will be using that chat log to collect questions. You can also use the raise hand feature to verbally ask a question. We do have a dedicated time for Q&A at the end of the session as well. And as ever, I'm nagging you to fill in an evaluation survey. The link will be posted in the chat log at the end of the session. So this brings me to introducing our speaker. So Dr. Magali Robert is the medical director of the Calgary Chronic Pain Center. She is a professor in the Department of Obstetrics and Gynecology, as well as in the Department of Anesthesia. She initially trained as a urogynecologist, and she became interested and drawn to pelvic pain at a time when there was minimal options and it wasn't spoken about. Dr. Robert has been treating pelvic pain for over 20 years, and this included a period of time treating male pelvic pain. She is a strong advocate for women's health, as well as advocating continuously for access to pain services. So welcome, Dr. Robert.
I did want to say I'm here in Calgary, and it is actually a privilege and an honor to actually, I think, live in Calgary in Alberta, as well as in Canada. And next slide, please. So I have nothing to disclose. And what I wanted to do is talk a little bit about today's objectives, and it's really what I would call an aperçu. It's impossible for me to talk about all aspects of pelvic pain, but what I really wanted to do was develop sort of an idea of a differential diagnosis for pelvic pain, how we can apply the biopsychosocial model of pain to pain diagnosis, and also to integrate this diagnosis to start to develop a plan moving forward. Next slide. So the first thing we want to think about is what are the most common chronic pain conditions? And already Carrie's given you a bit of a leeway into this. But if you take 2 seconds and you think, well, when I think of chronic pain, what do I think of? If you think of low back pain as your first idea, then you're actually right. Although disabling low back pain is seen in 7.3% of the population. And if we keep scrolling down, you'll see migraines are coming in. And we always talk about migraines at pain conferences and seen in 14.4%. And Carrie, you can keep bringing these in. Fibromyalgia is so common. And then we get to pelvic pain. Just a second here. 26% of the female population have chronic pelvic pain. 8% of men. So if we actually balance that out, that's 17% of the population. That actually is more than with migraines. And so you have to ask yourself, if this is so common, how come we're never talking about it? What's going on? So next slide, Carrie. And so the big question is, why are we silent about it? And when I use the word we here, I'm talking about we as a society. Why don't we talk about it? So the first thing we can think about is, you've all heard of the vagina monologues, incredibly popular. But what was the sequel to the vaginal monologues? It's not the elbow monologues or the low back monologues. Nobody would come to this. So there's something about the pelvic region that we need to take into context. So when I thought about this, I went to my knowledge incredible source, Cosmopolitan. And this is an issue that was I believe in August or July of this summer. And in there was an article that described what are the common words used to say vagina. And they stopped the list after 38 different terms for vagina. Now, if you think about it, how many different ways do you say neck? How many different ways do we say knee? There aren't that many. And so when we look at ourselves as a society and we think of the context and we start to begin to use a gender lens in terms of pelvic pain, we can recognize that the whole pelvic region is socially stigmatized. We talk about it as private areas of our bodies, and that area is actually heavily laden with meat and identity, parenting, sex, and pleasure. Because as you can see on Cosmopolitan, what is in big, bold letters? The truth about orgasms. So we don't talk about, again, we don't talk about the truth about our migraines, our low back pain. And so this is something that we need to take as a society to see this is women entering with chronic pelvic pain and what have they been exposed to moving forward. And next slide, please, Carrie. But we also have to think about ourselves as healthcare practitioners. What are our own biases? And I'll be honest, when I entered obstetrics and gynecology, I never thought I would be talking about sex. I never thought I would be dealing with chronic pelvic pain. Those were not the areas that I had been drawn to. And yet the more I seemed to get into this area of care, the more I recognize its importance. And if we think about the pelvic region, the other thing to think about is just how busy an area it is. And so what do? We urinate. We defecate, women menstruate, women have sex, and I use this word very broadly, whether it's penetrative intercourse, whether it's with toys, whether it's by touch, any sort of way. This area is certainly busy, and also for women, potentially with childbirth. So we can think of the pelvic region a little bit like excretion and reproduction. And because of this, it's brought us forward. And when people present with pelvic pain, it's been the past experience that we always said that this was in the realm of gynecologists. And the going diagnosis always that I hear is that, oh, it's endometriosis, it's dysmenorrhea. Oh, these women have had abuse. This is why they're here with pelvic pain. And yet, when we think about it from a gynecological perspective, what we find is that chronic pelvic pain is not gynecological in 80% of patients. So it's time that we start to look at it from a different perspective. Next slide, please, Carrie. So I think what makes pelvic pain difficult is because it is complex. It's complex because there's a lot of psychosocial constructs that are in this, as we've already spoken about, both as ourselves as healthcare providers, but potentially as a society in general. It's complex because we talk a lot about visceral areas, the bladder, the uterus, the bowel. We talk about hormonal changes, the fact that pain is predominantly seen in women, that it can be modulated by hormones as we see in endometriosis and dysmenorrhea, but also that the whole pelvic region is surrounded by a musculoskeletal network. So we're talking about the lumbopelvic region, incredibly important if we think about ambulation, the fact that the pelvic floor is part of our core muscles, which are really exactly that. They're the core, the basis to where we're for movement. And of course, as well, neurological, both the somatic nervous system as well as the autonomic system through the sympathetic parasympathetic system. So incredible amount of things happening in the pelvic region. Next slide, please, Carrie. And so let's think about this. Here's the next question. What is the most common chronic pelvic pain diagnosis after dysmotility disorder? So this is bowel disorders, because we know they're very, very common. And then we also have to take into account that 50% of women will have multiple diagnoses, and probably that number is actually underrated. So there's a number of ideas here that we're going to talk about. And as I said before, usually when you see a woman with pelvic pain, it's almost like, oh, refer to gynae. So you might think this is really cyclical pain. Pelvic pain is gynecological pain. You think the answer is A. But next slide, Carrie. What we're finding is it's actually much more complicated than this. If you said it was musculoskeletal, you're actually right. 50 to 90% of women will have pain originating from musculoskeletal structures. Oh my goodness, this is interesting. But pain and pelvic pain is even more interesting because there's so much things happening about around. So we talked about the visceral structures, and we can't ignore them. The uterus through dysmenorrhea, but also there's bladder and bowel that we talked about. And what happens is you get cross-talk, this visceral cross-sensitization that happens. So what we find is that 48% of women with bladder pain syndromes also have endometriosis, but 30 to 75% of individuals with bladder pain syndromes also have irritable bowel. So this is getting quite complicated. And over 40% of people with chronic pelvic pain are going to have irritable bowel disorders. And we see cyclical pain in at least 20 to 50% of people with pelvic pain. So visceral structures are really important in this crosstalk. And sometimes the way I explain it about how some of this crosstalk talks, even without pain, is you might notice that you never urinate and defecate at the same time. Why is that? Isn't that kind of interesting? Now, you might be sitting on the toilet at the same time, but they will never happen exactly at the same time. You might urinate first, then you defecate, or you might defecate, then you urinate. So there's always this communication that's happening in the viscera going on. But as well, remember, if 50 to 90% of women will have a musculoskeletal component to their pain, then these are talking somatic structures. And what we get is this visceral somatic convergence. So now there's cross-talk as well between somatic and visceral structures. And we see that convergence happening at the level of the spinal cord. And we can get that augmentation now of sensory input to the brain. And when we get to the brain, then the brain needs to make sense of all this information that's happening. And it's going to be contextual. It's going to be about this woman's previous experiences, about the context that she's taking all these sensations coming in for that whole pain experience to happen. So this is what makes pelvic pain so difficult in some ways. And sometimes I think that we've shied away from it, and we've never been very satisfied with some of the treatments we've done because all of this may be happening at the same time. Next slide, Carrie, please. And so what I hear a lot, remember, is that, oh, pelvic pain, oh, they have a history of abuse, this explains everything. But we have to take trauma or things that have happened in the past in context as well. So what's interesting is that, yes, all pain, so not just pelvic pain, is more prevalent in a women with a history of abuse, mental illness, and social stressors. But interestingly, just to make things more confusing, this is a PhD dissertation, and I quoted it perfectly, from a student in Toronto who had looked at all of the literature and said that there's very low quality evidence actually for increased risk of pain among victimized youths and adolescents and children compared to non-victimized youth. So maybe it's not that clear cut. And some of the things that they're talking about is that there are modulators. So if there are things that have happened in the past, adverse childhood events, there are modulators that are going to change that pain experience. And this is something we need to think about. That may be things like PTSD, interpretation of that experience. And then let's look at this tiny bit more carefully. Okay, so chronic pelvic pain, if we look at it, the odds ratio of childhood physical abuse, yes, we see it more in pelvic pain. We see sexual abuse, and this is compared to a population of people who've not experienced it, who don't have pelvic pain. Verbal emotional abuse, yes, the odds ratio are higher. But let's think about this a different way. How about arthritis? I don't know about you, but rheumatoid arthritis, I don't think of it as related to adverse childhood trauma or maybe to a history of abuse. But then looking at a population in the US, what we're finding is the adjusted relative risk, which is a little bit different than the odds ratio. But for intent and purposes, what we're seeing is there's also that association between arthritis and childhood abuse and childhood sexual abuse. And so what we're seeing is that even though trauma may be important, I think, and we need to identify it, its relationship to pelvic pain is actually much more complicated. It's not a linear relationship, and we can't attribute every experience a woman has to these traumatic events. But we need to identify them, and we need to address them in the treatment plan. But what's important is the context that individual is putting, the meaning around what's happened to them in the past. The context of perspective is the most important finding to these events. Next slide, please. And so it means, though, that we need to use a trauma-informed care approach. And I will tell you that when I first started in obstetrics and gynecology, I wasn't very aware of this. My thought was, well, if you're seeing a gynecologist, of course you're going to get a pelvic exam. Why else would you come? And yet, what I've recognized is that was not the right approach. And I will apologize to any woman who I see in the future who I may have actually placed in a very difficult position. And we do need to have that care approach. And now I definitely use it. We need to screen for it. We need to be aware of it. We need to acknowledge it. We need to take the history with the patient dressed, not undressed. We need to talk about a pelvic examination, what it's going to be, and make sure that the woman is comfortable with it. I'll always obtain consent before I do an examination, but also just before I do it. So before she changes, I'll get consent, and I will re-ask consent when I'm ready to do the examination and she's changed. I'll ask if she wants a chaperone in the room and who that chaperone could be, whether it's a family member, a friend, one of the nurses that I work with, anybody else. I will definitely ask for that, or ask them if they're comfortable with me as well. I will tell them that they have the power to stop the examination at any time. And I will always respect that decision, that they do not need an examination today, and that is actually completely all right. I will open it up if they have any questions about what I'm going to do or at any time during the examinations. Offering a mirror sometimes helps. I find I have a lot of women who say no. I have a lot of women who might feel more comfortable with it. These are options we bring up. There's a couple things that I catch residents, and these are OBGYN residents as well as family practice residents. Never tell a woman to relax before you're going to do a pelvic examination. It's a little bit like saying, don't think about the elephant, and that's all you can think about. So we never use the word relax. Never say spread your legs. And I always observe for verbal and nonverbal cues. And what do I mean by that? Is I'll look, has the woman made eye contact? Is she hesitating when she's answering some of my questions? And when I'm doing the examination, I'll also see how she's moving. Like, is her legs really closed? And I have to say, hey, are you okay? Are you sure you want to do this? And I'm finding that it's very difficult. And then I'll just back off and we'll have a frank conversation. Or if as soon as I touch her, she jumps, even though I'm always very careful of approaching the vulvar area slowly so the woman knows where I am, because as you know, she can't see me. I always bring the sheet down that's covering her so she can see my face. It's a little bit harder with a mask on, but still so she can see where I'm at, so she's not surprised. But if I see her very, I use the word jumpy, but nervous, then I'll just be frank and have that. And the other thing I'm very careful about now is women who dissociate during an examination. And either they may close their eyes, or if I ask them a question, they don't answer, or it looks like maybe the way I think of dissociate is they're not there. And I'll always be watching them at the time I'm doing. And at that time, I have actually sometimes myself stopped the examination. But again, always giving them the permission. And the idea with trauma-informed care is we need to empower women to be comfortable with the examination they're doing. Now this, I probably talk longer on this slide than I do with women in terms of how I'm doing this, but I think it's a very important to do this. And I've certainly have had women who have declined an examination, and I definitely respect it and bring it back later on, and we talk about it and we go there. And we just have a woman recently in our chronic pain program who took 6 months with our psychologist before she was ready for a pelvic examination. But the beauty of it is it went really, really well, and it was a positive experience for her. And I'd like to think it's set her up as well in the future for more success. Sorry, next slide, Carrie. So I like to think of pain a little bit like the tree of life, or we're going to call it the tree of pain, in that if we start at the bottom, at the roots, this is what we call nociceptive pain. And this is what Western medicine has really focused on. What is, let's say, wrong with the body that we can fix that's giving pain? And so we want to think of this as the roots. And then we think of now what we call nociplastic pain, and a little bit simplistic, think about it as the trunk of the tree. And this is where the sensory input has been modulated. It's changed. It may be augmented. It may actually not be coming from anything in the periphery. And that's a nociceplastic, or the trunk of the tree. And then we have those psychosocial comorbidities, which is more like the branches coming into the tree. And these psychosocial may be history of trauma. They may be depression, anxiety. I put in there sleep patterns, diet, experiences. This is the contextual approach to pelvic pain. And all these come together to give us an idea of the pain experience. Now, having said this, I'd like to think, and if you can think of somebody you've seen recently, a woman who's come to your office with pelvic pain, they may be different types of trees. So a woman may be more like a bush. The psychosocial is very important. Maybe she's more like a cactus, in which case the nociplastic pain is more important. Or maybe she's more like an aspen, and the nociceptive pain on the periphery, like aspens that have incredible root networks, or this. And part of what we need to do is to figure this out so we can get a better care management plan to try and bring this woman forward. So not everybody has all these aspects. And so this is what we're going to talk about next. Which kind of tree is this woman? Next slide, Carrie. So I'm going to talk a little bit about the roots, especially this nociceptive pain, because that's always where we focus. And what we're talking about here is this whole pain history. And for pelvic pain, we have to be comprehensive, because remember, there's all these visceral, somatic, neuropathic things that are coming in. So I think you all know how to take a pain history in of itself. What makes it better, what makes it worse, what's the referral pattern, that kind of history, previous history. Always ask for bowel function. Remember, dysmotility disorders, 50-80% of women have it. When it comes especially to pelvic, I asked about evacuation problems. Do you have to strain? Do you feel like you're empty after you've had a bowel movement? Have you had hemorrhoids? Because that means they're straining. What's going on there? I'll always ask bladder problems. We'll talk a little bit about some of the symptoms that come from there. Not often incontinence comes from pelvic pain. I'll ask a cyclical pattern to the pain. I'll ask a sexual history. And with the sexual history, I always ask for permission. So the way I like to bring it in, and everybody does it a little bit differently, but it's a difficult topic to bring up. And usually I'll say, many women who have a history of pelvic pain have struggle with intimacy, with the pain, with sexual activity. Are you okay if I ask you these questions? Sometimes women will spontaneously let you know, and you can take that down that road, or I'll bring it up this way and see. And this, if they say yes, this opens the door even to ask, are you in a relationship? What kind of relationship is this? What's going on? What about pain? So it brings this up. I'll take a musculoskeletal history, especially about low back pain, very common with pelvic pain, hip pain, any type of other pains. Is this a general pain pattern? So I'll see women with fibromyalgia, and then they have all sorts of myofascial pelvic pain. And the way I'll bring it in is, this is your fibromyalgia picture. It's also impacting your pelvis, but we don't talk about it very much. But this is part of this whole diagnosis that you have. So now let's approach it in maybe a slightly different way. We talked a little bit about the psychosocial factors that we need to bring in, and anything else that they know. On the left side of the screen here, I've put down sort of, this is an older study, and I don't think it's quite as accurate as it was before, because musculoskeletal disorders are much more common and are almost ubiquitous in pelvic pain. But what you're seeing is, like, it's not all cyclical pain. It's and we see less urological diagnosis, and probably for most people it's a multitude of diagnoses. Next slide, please, Carrie. And so when we talk about cyclical pain, this is the big question. Would you wax your legs just before your period? Now, this is probably somebody, should be geared to somebody who's menstruating. So I apologize to everybody else, but the answer is no, because your pain experience with waxing your legs is going to be higher. So we've got to be careful when we talk about cyclical pain. We know from even people with no pain, there is a cyclical pattern to pain, and different types of pain, whether it's pressure, whether it's thermal, will change with the menstrual cycle. And what we're finding is especially pressure pain tends to be higher in the luteal phase, so just before your menses. And what we see is that all pain gets worse before menses. Migraines get worse. We even have a name for it, right? We call them menstrual migraines. IBS gets worse. Fibromyalgia gets worse premenstrually. And so we've got to be careful with the idea of cyclical pain, because you have to bring it, again, in context of where it is along the whole pain spectrum. Next slide, please, Carrie. So, but when we talk gynecology, we think of two things. One is dysmenorrhea, and these are just painful periods. And I shouldn't say just, because what I've heard a lot from women is, I have pain with my periods. I spend one day in bed, but this is normal. No, this is not normal. Pain is not something that women should have to bear, and this is not a normal part of entering into the reproductive years. And so when we think of dysmenorrhea, especially in young women, we want to think of primary or secondary, knowing that most women will come with just primary. That's the most common type of gynecological pain, but we should be very, very aggressive in treating it in young women, because there is a lot of thought pattern that the more pain we experience, the lower our pain thresholds have, and we know that. And so we don't want to set up adolescent women to go down that pain a pathway if we can help it. So we need to be more aggressive early on in people presenting with dysmenorrhea. Now, endometriosis. Endometriosis is the answer to every pelvic pain, and there is not a woman who's going to come in and says, could this be endometriosis? And so when we talk about endometriosis, we talk about ectopic endometrium. So endometrium outside of the uterus. It happens in every woman when they menstruate, but then we have mechanisms to clean it up. But for some women, that mechanism doesn't seem to be, their house cleaning isn't quite as good. And that starts to implant, and usually begins with dysmenorrhea. But what we say is, we say a triad for endometriosis is dysmenorrhea, pelvic pain, and dyspareunia. But what you're going to find out is it's almost there with everybody. And yet we don't see endometriosis with everybody. And rarely, there's a lot of case reports about endometriosis being in the brain, being in your lungs. It can also definitely affect the bowel, bladder. But this is more the exception to endo than the common presentation. Next slide. So here's where things become interesting for endometriosis. We know that chronic pelvic pain, 28 to let's say 30% of women will find endo. But interestingly, about 30% of women who have endo are asymptomatic. They have no pain. So it's not a linear relationship between endo and pain. There's more going on. It's much more complicated than that. And already we've seen there's a lack of correlation between lesions, how many there are, where they are, and pain. We know as well that hormonal suppression sometimes is insufficient for pain relief. I didn't say for management of endometriosis, I'm saying management of pain. And in women who are going for laparoscopic surgery for their endo, pain tends to help for 6 to 12 months after surgery. And then we often see an increase in pain. And why is that? Well, my pet theory is, in fact, it had nothing to do with endo. It had to do actually with the anesthetic that women received and the muscle relaxation they received at the time of surgery, not because of the endometriosis excision that they had. So we want to think of endo. It's not a linear relationship. It's much more complicated. Next slide, Carrie. And so if it's not always endo, what goes on in women who have a diagnosis of endo, who now continue to have pain? Well, there's a number of things we need to think about. So one of them is people are talking about these neuroplastic changes, the perpetuating plane. This was the nociplastic area, the fact, the tree trunk. We've got that all revved up now, and treating the roots is not sufficient without treating the tree trunk. Or maybe we're looking at other causes of pain. That is not endo. It was never endo because not every woman experiences. Is it myofascial? If you could click that, please. And here's an interesting study that really says what a lot of us already knew. Is in a study, and this was just published in 2021, all participants who had endo treated had pelvic floor muscle spasms, and 77% had them in at least 4 of the 6 pelvic muscles examined. And when they were getting their examination, all women acknowledged that this was a major focus of their pain, not where the endometriosis was. Interestingly as well, 57% had abdominal pain on palpation, and 30% of women had sacroiliac joint pain. Well, that's kind of fascinating, isn't it? Next slide, Carrie. And so what is it about this pelvic floor, and what do we mean about it? I like to use the word pelvic floor because if we start to separate them in all the muscles that are there, then I find you kind of get lost in the anatomy. And as I'm going to show you, that's not necessarily as important. But I think what's important when you recognize the pelvic floor is what does it do? It's one of the core muscles. It's intricately linked with breathing. It has structures that go through it, the urethra, the vagina, the rectum. And it's the most interesting muscle because it's one of the few muscles in the body that actually inserts on another muscle, the obturator internus, a muscle that's important in external rotation of the hips. Next slide. So what does it mean? It means that women who present with musculoskeletal pain come in with a variety of symptoms. Often they'll describe it as a dull ache, a heavy pressure, things are falling out is often what I hear. Worse with movement, worse at the end of the day. You can imagine if there's tightness around the urethra, what are they going to complain of? Urinary retention, and I have women who cannot pee and need to catheterize because their pelvic floor is so tight. They may present with overactive bladder or with urethral syndrome because you can imagine the muscles tightening around the urethra all day long. With the vagina, if they come in with tightness there, they're going to complain of dyspareunia, pain that lingers after intercourse. Oftentimes women will say it's almost like they hit a shelf or a wall. That's what their partners describe for pain. And you have the rectum coming in the back. So we're getting now anismus, dyschezia, constipation, hemorrhoids as they're trying to evacuate and they're bearing down. And as they keep bearing down, they're going to develop prolapse. And so I'll get a lot of referrals as a urogynecologist for prolapse when the primary problem is actually pelvic pain and this tightness that's going on. So never do we want to bring those women to surgery to fix their prolapse, because a prolapse is a consequence, not a result of their pain, not the cause. And like I said, because it inserts, then we get into hip pain and low back pain, and as well that obturator internus, giving a lot of actually urinary frequency and urgency symptoms. So a lot of things happening in this neighborhood. Next slide, please, Carrie. So this is my, simplified. I think simplified may be an understatement here of how to think about this and how do we separate some of these common diagnoses of pain. And this is by no means a comprehensive differential diagnosis. Musculoskeletal, endometriosis, painful bladder syndrome, vulvodynia, pudendal. They all give you pain. So we can agree on that. They all cause some kind of sexual dysfunction. MSK pain pretty well gives you everything, or potentially can give you everything. Endometriosis tends to be more of a cyclical nature, at least at the beginning of what's going on. Painful bladder, they may complain more of bladder symptoms. Vulvodynia is often provoked with touch, and it seems to be better localized. And pudendal neuropathies is mainly with sitting, but it's not a common diagnosis. So I'll see it in women who've had trauma in the pelvic region, or potentially cyclists that have done a lot of cycling. So these are just a general idea, but remember that visceral connection, the viscerosomatic connection. So most women are going to present with a combination of these, and almost always some kind of myofascial component to it. And that makes sense, right? What we do, even if we have, let's say, pain that is initiated by endo, we hold ourselves, we protect ourselves from pain, and eventually then that becomes a problem as well. Next slide, please, Carrie. And so the other thing we see is pain with intercourse. Remember, that's a hallmark of endo, but so it's a hallmark of all of these differential diagnosis as well. Even, vaginal dryness will give you pain. Vulvar pain, that's the vulvodynia, will give you pain. They all present maybe a little bit slightly differently, but there's often an overlap between them. Myofascial pain, almost always we see it with vulvar pain as well. Endometriosis tends to be deeper and positional, and painful bladder often associated with bladder symptoms. So we can't take dyspareunia as a hallmark of endometriosis. It's only one of almost everybody who has some degree of pelvic pain. No, next slide, Carrie. So let's talk a little bit about the physical examination and how we do it. I start right from the beginning. I'll watch how a woman walks and how she moves, even as she's coming down the hall or as she's leaving. That will already give you a lot of information. I'll see how she's sitting. Is she sitting on the side of the chair? Is she sitting on one cheek? Does she get up a lot? And then I'll start with the examination. Again, always informed consent. I'll always tell her I'll start there. And on examination, and I don't pretend to be an NMSK physician, and I'm certainly not a family doctor. So what I check is I just check for pain along the lower back, especially. And I'll always check at the sacroiliac joints if they have pain, and that's called a provocation test. I'll often like the one leg standing test. And why do I like that? It's a very non-specific test. So remember, that's when you have a woman stand and you just ask her to lift one leg like she's going up a stair, and then you're going to have her bring it back down and then do the other one. And what am I looking for? You know, is she doing a Trendelenburg and she can't do it? Or is she what I call ratcheting? So she has difficulty, especially bringing the leg back down. What's the stance like? And what that's going to do is that's a very non-specific test, but it to me opens up a conversation with the woman. If she can't do it, I'll say, wow, are you not surprised you have pain? Like even just moving is difficult for you. So this makes a lot of sense. We need to back this up, and you need to have that lumbopelvic stability. I'll always do as well an active straight leg test. And this is the picture on the left here. So I have the woman lying down. I'll ask her, you know, especially I'll usually put my hand, can you lift your leg and hold my hand? And I'll say, does one side feel like the other side? I'm looking if her pelvis is shifting as she's doing it. Always ask a non-leading question. And this is really as well, it's checking both these, it checks a lot of things, but if I've had a positive provocation test in the back across the SI joints and a positive active straight leg testing, I'll often add compression to see if that helps. But that to me usually as well, we need to get this looked at a little closer, usually with a physiotherapist. So even just beginning there gives you a good idea of the core stability, of her ability to transfer weight through that lumbopelvic region. Next slide. And so then I'll go on with the abdominal examination. And with the abdominal, I'll always check around the inguinal area. I'll check for bloating. And if I see it, I'll always acknowledge it for women. But I'm doing gentle palpation. And what am I looking for? I'm looking for sensitivity. I'm looking for guarding. I'm looking for the tone. Is it tight? And if I can get down to the psoas muscle, I'll palpate it. But already it gives me an idea of what's going on. And I'll always ask, where is the pain being referred to? Next slide. And the referral patterns are very difficult to tell in pelvic pain. As you can see over on the left, pelvic floor will actually radiate to the lower quadrants. So having a lower quadrant pain could still be myofascial. But we also have all the visceral organs in this area. And so we've got to be really careful with referral patterns to the abdominal wall. And on the right side, what I've done is a bit of a schematic. Any of those areas could be related to pelvic pain, and that's usually the area they're drawn to. Next slide. And so then, I think this was a bit of a repeat. Sorry. And then I'll get into the pelvic examination following informed consent. I tend to do a sensory examination first. That also give me a woman an idea. Just take a Q-tip. I start at the knee and I come down towards the vulvar area, and that just hits right away. L2 to S4. Is that normal? Is that symmetric? And if it's not, then I try map it out to see if that's different. Most of the times that's normal. Next slide. And then I start with the external examination. And this is my new favorite area, especially if you're not comfortable with a pelvic examination. So the first thing on the left is I'll see essentially what's going on. And if the woman's pelvic floor is really tight, you can almost just look by looking at the introitus, you're going to say, oh my goodness, you know, doing a speculum here would be very difficult. I rarely do a speculum examination for pain. The next area I'll examine is on the ischial tuberosities. And why? Because as you can see here, the transverse perineum crosses right across the ischial tuberosities. Already the lower pelvic floor region, the external part, it's giving me a good idea what's going on. And I'll even over the perineal body, and just inferior to the transverse perineum, just below the ischial tuberosities is the inferior border, the pudendal nerve. So it gives me an idea already what I can expect on a pelvic examination. And I have not yet done a pelvic, and I can have a pretty good idea what's going to happen next. Next slide. And then the Q-tip test. Usually I do it right around the hymenal ring. This is looking for vulvodynia or vulvar pain. I've had a lot of women where I'll check around the urethra Skene's glands, because often that will mimic painful bladder syndrome. If she has so much pain I can barely touch her, I'll often put some 2% xylocaine gel to carry on with the rest of the exam if she's consenting to that. Otherwise, the rest of your exam is almost impossible to do. Next slide. And then I do the pelvic examination, always with one finger, always looking at the woman, always asking, what is she feeling, what's going on? I start with the finger in the back of the vagina, pushing a little bit towards the rectum. So she just kind of gets used to that pressure. And then I'm going to start to move laterally. So even without knowing the muscles and not knowing what's going on, what am I looking for? I'm looking for some symmetry between both sides of the pelvis. I'm looking if it's giving her pain. Is this a similar pain? Is this a different pain? What's the radiation? Do I feel bands in there? If I put my finger in the vagina and she's already telling me this is a huge amount of pain, I already know this is hyperalgesia. And so this is almost the end of the examinations at that point. And I'll go up to the ischial spines where I've put these X's here. And this is where I'll check for the pudendal nerve, although it's often not just the pudendal nerve. So you have to be very careful to put the whole picture together. But so even if you're saying, she says, oh my goodness, that's my pain, without knowing exactly where you are, that's okay. You already have an idea that this is musculoskeletal pain that's happening. Next slide. And then I'll do the rest of the pelvis. Check the bladder, the urethra, the cul-de-sac, look for cervical motion tenderness. But if the exam has been already very, very tender, you can't do it at that appointment. So it really depends on the exam. I'll only do a rectal examination if I need to. It gives you a better pudendal nerve exam, better access to the cul-de-sac, and sometimes it's really good, especially if she has a lot of hyperalgesia in the vagina. Next slide, please. And so after this, you're going to bring this all together. You're going to look at the psychosocial, the nociplastic, the nociceptive, knowing you're going to have multiple diagnoses. And this is where your care plan begins. Next slide. And so just to make things a tiny bit more confusing, is there's actually two studies I just want to briefly mention on. One that's relatively soon, where they used people with endometriosis and pain on a wait list. And just by doing psychotherapy and acupuncture, their pain levels went down. They didn't even treat the endo per se. And we see the same thing with vulvar pain, that cognitive behavioral therapy is actually quite successful for vulvar pain. And it compares to surgery, and it compares even to steroid creams. So that this gives you an idea that pelvic pain can be much more complex, and we need to look at that full picture. Next slide. And so I would be negligent if I didn't talk just 2 seconds about opiates for pelvic pain. The American College does not recommend the use of opiates for pelvic pain. The SOGC says under adequate supervision you can prescribe, but actually they're rewriting the chronic pelvic pain guidelines. And I've just helped with the opiate guidelines for pelvic pain, and I can tell you that there is no evidence that they actually work or make a difference. Next slide. And so let's wrap it up. We talked about the the objectives, and I was trying to give you a bit of an overview of all of pelvic pain and what is there really. I hope you've appreciated that the pelvic pain is complex. It often, if not always, involves musculoskeletal plus other potential nociceptive factors. We should always treat dysmenorrhea and not just say it's normal. That we need to find, let's say, that woman's tree and think of it as a tree of pain, the nociceptive, the nociplastic, as well as contextual, and bring that together. And when we look at a care plan, the way I talk about it is pain is like a cake. Okay, it's got so many factors that if we want to make a good cake, we need all the ingredients. And if your ingredient is only nociceptive, something like endometriosis, you only have one ingredient. You're making yourself an omelet, not a cake. And so we need to look at all of this if we want good treatment. Next slide. And so, first of all, thank you very much. Questions, and really, maybe we should think of pelvic pain as really a tree cake.
Thank you very much, Dr. Robert. We have a few questions. Actually, I've had a couple come in private. I don't think they meant to. Some of the centers really about what language to use. And so we had a question: when you are doing an exam, a pelvic exam, what kind of language do you use? The person asked, sometimes they say, can you relax your buttocks? And we're saying, what words would you use? Like, how do we approach that?
So I think sometimes you have to change a little bit depending on the woman that you see and what she's comfortable with. I'm finding as I get older, I can be more, I myself am more relaxed, and and that comes across. And sometimes I'll crack some jokes with patients, and some of them appreciate it, but I'm always careful about who I do that with and to make sure that they're comfortable. So the first thing I'll do is I'll always tell the woman exactly what I'm doing. So I'm going to touch you on the knee here. Do you feel this? Yes. I'm going to touch you just on the inside of the thigh. Is that okay? What are you doing? I'll ask her for permission. I'm just going to touch you on the labia. So one thing I've done is, even though I said there were 38 ways to talk about the wording of vagina, I always do use medical term. Even though we're told we shouldn't, sometimes we say we should use the same language people are using, but I'm not going to say, gee, I'm going to examine your pussy right now. I think that's completely inappropriate. So I always use medical term, and I'll bring it out to women and see if they understand. And always the word I say, let's say when I put pressure in the vagina, I said, you're going to feel some pressure in the back of the vagina. Do you feel my finger there? Do you want to melt into my finger? And then I'll give the cue back. Oh yes, that's excellent. Very well. Is this giving you any pain? Are you okay? So I'll always use those kind of vocabulary words to move it forward. And sometimes I'll say, wow, isn't it interesting that this is giving you the pain that you're having? I'm just at the opening of your vagina. And to give that feedback. The one thing we do is we've always draped women across the knees. I'll always bring it down so that exactly they can see my face. I bring the head of the bed up a tiny bit so that they can actually observe me. So it makes it a little bit less frightening. So these are some of the few tricks that I've done along the way. And always just ask. And I think I've had a lot of positive feedback by people telling me. And sometimes when I don't know, I'm just very honest about it. I don't know. I'm sorry. Tell me, what would you like? I'm trying. Please teach me. And I've learned most of it from patients.
Oh, that's great. Thank you. We have another question that was just sort of again on that language, on the subject of medical terms during the exam. Do you teach basic anatomy to the patient before the exam? Do they understand the terms? Like, how do you approach that?
So I've gone to a lot of metaphors. As you can see, I used a few metaphors here as well, and I seem to be using them more and more to talk about pain. And, we talk about pain neuroscience education, and I think that's something that's been really lacking behind, especially in pelvic pain, and try to bring it there. So I do talk about it. I do have pictures on the wall showing pelvic anatomy. And what I do, I often will go on the internet. What I use a lot for pictures on the internet is especially of the muscles and of referral patterns, because how many times, and I will always try and gently bring the woman to where she's at. So what do I see a lot? Just recently I saw a woman, bladder pain. She had bladder pain. I said, no, tell me where your pain is. And I said, oh, that's suprapubic pain. So let's call it by where you're feeling it. Let's not put the context into it. And as I was doing it, it was muscular. And I said, I'm not on your bladder. Isn't it interesting how the brain is processing this, that you're feeling it in the bladder, even though I'm not even close to your bladder. So restructuring that during the examination and then bringing it back often. Like I say, I do spend time on the internet to try and find pictures to show these referral patterns so people can understand. And then I'll just always bring it back. Your bladder pain. Oh, you mean your suprapubic pain? Trying to reframe it.
Great. How do you approach the women who believe their pain is gynae? And it's probably the majority, and maybe as family docs, we might be part of that problem, and bridge them over that this is MSK, and is sort of what are the most common MSK things that you see us missing that end up in the chronic pain clinic in Calgary?
Yeah, wow, that's an excellent question. And I think part of this idea about the tree is that there are people we're not going to shift. And I've had women I have had to operate on before they cannot shift until that is happening. And that's unfortunate in many ways, but that is our reality we live in. And a lot of people will ask for that. What I'm really careful with is trying not to go back to interventions. So it's very common we order an ultrasound, right? But when that ultrasound comes back, that should be the end of the story. And if they come in and they tell me they want, let's say, an MRI, I'll say, well, what are you looking for with your MRI? Like, do you recognize endo's not picked up by MRI? And those sort of things. And I'm very careful about using the word endo because that's a label we throw out very quickly, but it's actually a surgical diagnosis, right? And so we don't know. We can suspect it, but we don't actually know. So I think sometimes women and all pain patients actually have to walk a certain road before you can bring them back into this. And I think the idea is starting to plant that seed, have that talk, go from there. And sometimes you're not going to be able to avoid it, especially if you go on the internet, and endo is the answer to every woman's pelvic pain. And we can't get away from that. So I think that's the part that's maybe frustrating, and maybe over time we'll get better education. The way I look at it now is I do bring up that study that, do you recognize that 90% of women with endo pain actually have muscular. I talk about the guarding and how we protect ourselves and how that can also be a problem. And women don't believe it. And I say, have you ever heard of people with low back pain who can't get out of bed? And everybody's heard of them. And I say, well, this is the same thing happening. And so let's treat that and see where you are from there. But if you find a woman just cannot accept it, then I don't think it's wrong to send them to a gynecologist to have that discussion, but then to bring them back and to say, okay, so you have that. Now, what does that mean? And how can we now look at different areas? And maybe we close that, and maybe, this is taken care of. So now let's talk pain.
Oh, that's great. Thank you. And I see we're right at time. I want to thank you very much for an excellent presentation, thought-provoking, and at the end of my career in practice, wish I had thought of things as a tree, but that is, it's great. We do record the session, and if you have any other questions, if you let them let me know. I'll relay them on. I just want to let everyone know the March Collaboration Forum is on March 24th, and it's on opioid use disorders or opioid use in older adults, ideal versus the actual patient journey. So we're looking forward to that. Also in April, we do have a collaboration actually with the Calgary Chronic Pain Center and ourselves, and we're looking at a chronic pain echo. So stay tuned for that. Echo is an interactive online medical education process that has been around for a long time, and it's really, you bring your cases that are tough to discuss, and we'll go through it with a hub team from the Chronic Pain Center, as well as pharmacists and other colleagues that have experience in managing complexity in family medicine, basically. So we're gonna looking forward to that, and it's an all teach, all learn. So more information will be coming out through the ACFP as well as through PCNs and all different ways to communicate. So stay tuned. If you're not a member, you can always join, and you'll get all this information sent to you regularly. So we'd be happy to have you join and help us out in education and learning how to up our game, basically in managing chronic pain and substance use disorders in family practice. So once again, thank you so much, Dr. Robert, for an excellent session. And thank you everyone for attending tonight. And we look forward to seeing you in March.